Hello, good evening, everyone. Dear colleagues and friends, it gives me a great pleasure to welcome you and thank you for joining us in this scientific webinar on NMO spectrum disease. This webinar is one of the educational activities of the Emirate Neurology Society, and I thank Dr. Sohail for his support. The topic tonight is NMO spectrum multidisciplinary approach, so it's something new for us. This webinar is sponsored by Roche, organized by MCO, and endorsed by the MNs. Thanks for all for their contribution. This is an interactive webinar, so we invite you, we encourage you to put your questions, submit your question in the Q&A icon. You see it down at the bottom of the screen, and the speakers will be more than happy to address your questions. This webinar is CME accredited, so the organizers, the MCO, will be notifying you about how to get your CME certificate. The agenda is very interesting. We have a panel of distinguished speakers. So the first speaker will be Dr. Luai Adoueki. He is Associate Staff Physician, Pediatric Ophthalmology, Eye Institute, Cleveland Clinic, Abu Dhabi. And the second speaker, we'll go back to the agenda, please, will be Dr. Alauddin Ahmed Saleh, Senior Radiologist in the Neurospinal Hospital in Dubai. And his topic will be, is brain imaging needed for diagnosis of NMOSD? And the third speaker will be Dr. Suzanne Ibrahim Nouri. She is Head of the Neurology Department, Associate Professor, Medical College, University Hospital in Sharjah. And now I'm delighted to welcome and introduce our first speaker, Dr. Luai Adoueki, and his topic will be on you spot it, you got it. So Dr. Luai, the floor is yours, please.
Optic neuritis. Our understanding for optic neuritis has changed over the past few years. We have newcomers, and one of the newcomers is NMOSD related optic neuritis. Today, I'm going to help you to spot these patients because once you spot it, you got it. My name is Luai Adoueki. I'm a pediatric ophthalmologist / neuro-ophthalmologist at Cleveland Clinic, Abu Dhabi. These are my disclosures, and these are some disclaimers regarding the presentation today. And let me start with the take-home messages. First, be vigilant, be prepared and alerted to atypical features of optic neuritis. Recurrent optic neuritis with poor recovery, sequential optic neuritis, simultaneous optic neuritis. These are atypical features that you have to look for. The second thing is that you have to learn some new questions and add it to your history taking to spot these patients. The second thing is that be prepared, and I want to correct it. You have to be aggressive with treatment. Again, all what we know, or most of what we know about optic neuritis came from the optic neuritis treatment trial. And this has changed over the past few years. So be ready, be prepared, and be aggressive with treatment. To know how atypical patients with optic neuritis look like, we have to know and understand how the typical patient would present. So this is a story of a typical patient with optic neuritis. And when I mean by typical, I mean idiopathic or MS-related optic neuritis. This is a 30-year-old woman who presented with pain and vision loss for a few days. The rest of the history was insignificant. Going forward, the examination, you see the vision is slightly decreased in the right eye. She has some dyschromatopsia, and she has an afferent pupillary defect. This is your typical patients with optic neuritis. The patient sees nothing, and the doctor sees nothing. What's next? No OCT. You look on both sides, and exactly the same. No nerve fiber layer loss. The visual field, early arcuate defect, as you can see on your right side. This is a typical patient of optic neuritis. The typical workup includes MRI of the brain and MRI of the orbit. This is the MRI of the orbit. And you can see the short enhancement of the optic nerve in both coronal and axial images. What's next? MRI of the brain. And you can see here the typical white matter lesions that you would expect in patients with optic neuritis, or sorry, with MS-related optic neuritis. How to treat these patients? Now, in this patient in particular, you can use the optic neuritis treatment trial because it applies to these patients. Most of the patients in the optic neuritis treatment trial, they used to look like this. And in this patient, we offer treatment, and actually, she refused it. And on the follow-up visit, her vision came back to normal. This is your typical patient of optic neuritis. Let's see how the atypical patient looks like. This is your first case. She's a 22-year-old female. And 2 lines under simultaneous. She presented with simultaneous vision loss that started in one eye and then involved the other eye over 4 to 5 days. In the review system, she has some GI symptoms, and this is of high importance to look for in patients with optic neuritis. Also, the family history. She has a family history of autoimmune disease. So with this history, let's go to the examination. Vision is decreased in both eyes. She has dyschromatopsia in both eyes. No afferent pupillary defect as expected. And when you look at the back of the eye, everything looks healthy, as you can see in these images. So optic nerve look healthy in both eyes. What's next? The OCT. Remember the OCT that we have done in the first case? Look at the OCT here. There's early loss of the nerve fibers in the left eye. There's a new study that we added to patients with optic neuritis, and it is the ganglion cell layer analysis. We look for the ganglion cell layer in the macula, and usually the damage starts here, so you can spot it earlier before you see it in the optic nerve. And as you can see here, the patient has lost already some fibers in both eyes. What's next? Same thing, MRI of the brain and the orbit. Here you can see enhancement of the optic chiasm and optic tracts. This is atypical for MS-related optic neuritis. This is the patient with NMOSD optic neuritis. So the first case tell you that patient with simultaneous vision loss, patient with chiasmal or retrochiasmal involvement, these are your atypical patients, and these needs different workup and also different treatment that we'll talk about later on. Second case, a 43-year-old female coming with decreased vision in her right eye. She has a history of optic neuritis in both eyes before. However, her baseline in the right eye and prior exam was 2020. So she's coming with vision loss in her good eye. She has history of MS on treatment, and she's complaining of some fleeting paresthesia. This is very important. Let's go back to the exam. Let's go forward for the examination. Visual acuity is decreased, has dropped in the right eye from 2020 to 2200. This has dyschromatopsia, and the optic nerve is pale in both eyes. And this is what we're going to see in the next slide. Looking at the visual field, dense scotoma in her only seeing eye. This is very atypical for MS-related optic neuritis. To leave this amount of damage in the optic nerve, I would not see it in most of my patients with MS-related optic neuritis. When I see it, I start to think about atypical causes, whatever it is, but MS will be at the bottom of my differential diagnosis. OCT, diffuse loss of the nerve fibers in both eyes. What's next? Same thing, MRI of the orbit, MRI of the brain. And as you can see here, and I have to focus on the segment of the optic nerve that has been affected. So instead of if you remember the first patient, it was just retrobulbar, just close to the eye. This part of the eye that is affected, the optic nerve that is affected here, is the posterior segment of the optic nerve. This is also another feature that is atypical for optic neuritis. So this is an MRI finding that tell you that there's something else going on. This patient has 2 features that tells us that this is likely atypical optic neuritis. The 2 features are the following: recurrent optic neuritis with poor recovery. Even if the patient was diagnosed with the MS, you have to keep in mind that many patients are diagnosed or labeled as MS, and they really have something else going on, and it can be neuromyelitis optica. So recurrent optic neuritis with poor recovery, this is an indication for atypical workup. The second thing is the location, which segment of the optic nerve has been affected. And for this patient, it was the posterior segment, just pre-chiasmal. And this is also something that I don't usually see in patients with typical optic neuritis. Third case, a 49-year-old female patient coming with decreased vision in one eye, giving the same typical history of pain that following that she developed the blurry vision. No other symptoms. Let's move forward to the examination. Look at the visual acuity, 2400. Remember the first patient, the typical patient usually have a vision better than, I would say, 2200. Any patient comes with a vision that is worse than 2200, this is atypical. And you have to prove that it is typical by the MRI or examination. Otherwise, it should be treated in the acute phase as atypical optic neuritis. The patient has a dyschromatopsia and afferent pupillary defect. Again, the optic nerve looks normal. Look at this scotoma, dense scotoma in the right eye. That tells you that there's something atypical happening, severe vision loss with dense scotoma. And what is next? It's the MRI. This is the MRI of the orbit with fat saturation. And as you can see here, the lung enhancement of the optic nerve. It's almost taking the whole part, the whole optic nerve from the eye all the way from the chiasm. This is again, the longitudinal enhancement of the optic nerve is atypical for MS-related or idiopathic optic neuritis. If you see these patients require aggressive treatment. Next, the MRI of the brain is normal. You know, long time ago, when we used to see these patients with normal MRI, it was such a relief because we would just say this is your patient to the patient that you don't have MS. But now, with our understanding of other pathologies, usually when I see MRI that is normal, that raises a lot of question marks. Are we dealing with atypical optic neuritis? So this patient had many features that tell you that this is atypical optic neuritis. First, the severely decreased vision at nadir. The second thing is the long enhancement of the optic nerve. And will add the third one, which is an otherwise normal MRI, or MRI that does not show features typical for MS. These are patients that require from you more attention. You have to spot them early, and you have to treat them early. After discussing these three common presentations of NMOSD related optic neuritis, let's go and discuss an evolving paradigm for acute management of optic neuritis. So how does it start? Well, the management always, especially in neuro-ophthalmology, it starts with taking good history. So history about prior optic neuritis with poor vision recovery. This should raise question marks and suspicions about atypical optic neuritis. The second thing is that you have to learn, if you are going to see patients with optic neuritis, you have to relearn what questions you have to ask about. And one of the most important questions that you have to ask your next patients with optic neuritis about is the area postrema symptoms. So ask about hiccups, nausea, vomiting, anything that lasts for more than 48 hours. Actually, sometimes I go on the chart and look for any recent GI symptoms, admission for gastroenteritis. This should be something that I sometimes look for and raises question marks about atypical optic neuritis. Painful muscle spasm and narcolepsy, so atypical sleeping patterns. These are questions that you have to learn and you have to ask your patient about when you see next time a patient with optic neuritis. Lastly, ask about autoimmune diseases, because we know that patients with NMOSD tend to have other ongoing autoimmune disease like SLE or thyroid dysfunctions. Also, you have to ask about malignancies, especially in patients who are elderly. So when I see a patient with NMOSD or atypical optic neuritis who has these features, I usually look for paraneoplastic. So I start to look for other malignancies, underlying malignancies. What is next after taking good history? This is what I do. I do an OCT of the optic nerve. I'm looking for early loss in the nerve fibers. And when it happens so early, it tells me that what is coming is really bad and I have to anticipate more damage. So I try to act much faster. The next one, this is very important. If this is one of the messages that I want to stress on this visit, OCT of the macula, it's very important. Well, first you look at the structures and you look for microcystic changes. We know that the NMOSD affect the Muller cells in the retina, and these patients can have these microcystic changes. So I look for these changes early on. The other thing is a special scan for the ganglion cell layer to give us an idea about the map, how the patient ganglion cell layer looks like. So if there's any loss, I tend to also act really fast. The visual field, I believe everybody does that. It's part of the workup that you do for these patients, and I keep an eye on the mean deviation. The next question is about what do you do when you see a patient with optic neuritis? Well, I will talk about it in a second, but these are the examination. It's a very long list of tests that you can do for these patients, but this is what I do. I do the CBC, I check for an MO, I check for MOG, and also I request an urgent MRI of the brain and the orbit. It has to be with and without contrast. So this is my recipe. It doesn't apply for every single patient, but this is what I do for my patients. Finally, the acute management. So how do I treat patients with optic neuritis? First of all, I base my management based on one thing, the visual acuity at presentation. So if I have a patient with 2100 or better, these patients, I usually treat them as an outpatient. I request the MRI of the brain and the orbit, urgent to be done within 24 hours, but most of these patients end up with outpatient treatment and plus minus IV methylprednisolone. So many patients with vision, with good vision, I usually treat them without anything, with just monitoring. You don't need to do anything for these patients because the optic neuritis treatment trial have taught us about patients with a typical optic neuritis that the treatment is only to speed up recovery. But again, this is when the vision is 2100 or better. When I have a patient with 2100 to 2300, this is when I rely more on the MRI and start to look for the findings, atypical findings. If the patient has MS typical lesions, this is the patient that I can also treat as an outpatient with IV methylprednisolone. If the patient had MRI that shows atypical findings, these patients requires from me more close monitoring. So I admit these patients, I give IV methylprednisolone plus minus flex. It depends on what I see in the MRI, the findings. Is it lung enhancement? Is it posterior enhancement? Is it the chiasm? Is it retrochiasmal? How does it look like? How the OCT look like? Finally, if the vision is 2400 or worse, this is a patient who's coming to you with almost blind eye, and treating it with steroids is most likely will not be enough. These patients that now in my practice require admission, and we start them right away on Plex. I understand the side effects that can be associated with this treatment, but different studies looked at MS-related optic neuritis, looked at NMOSD, and we know that hyperacute treatment, that the treatment needed within the first 48 hours. And as the time passes, the chances of partial recovery or no recovery increases. So when you see your next patient, keep an eye on the vision and look for atypical findings in the MRI. This is my assessment and this is my management for patients with optic neuritis. Finally, I'll go back to my take-home messages. First one is be alert, ask new questions, and look for atypical features in optic neuritis. Be prepared and be aggressive in your treatment, because sometimes, actually in most times, time equals vision in these patients. Thank you so much. Looking forward to the discussion at the end of this meeting and happy to answer all of your questions. Thank you.